Hello, everyone. Welcome back to the Advocai Health Podcast. As you can see, there's a bit of a transition here. We are actually both in the same room.
Yes,
It's
yes,
pretty
we are.
crazy.
This is my room. Right now, you may or may not get the full picture of it because we've got a couple of different angles that
Yeah,
we're playing with.
I
So
see.
we've got one on me. You guys can see the one on Omar. We've got a central camera. I don't know if you guys can see. We might
Yeah.
use.
Might use
So,
you. Yeah.
Stay tuned for how this works out because the editing is going to be a nightmare. But
Nightmare.
otherwise, yes, welcome to my room and our first ever in-person
In-person podcast.
episode. Hopefully, we'll do more.
Yeah.
And maybe one day we'll have like a proper studio. But for now,
Fingers
this is where
crossed.
it's starting out. All right. Should we get into the topic for today?
Yeah, of course. So, I don't know if you guys have read the news recently, but Alberta is about to do something no Canadian province has actually ever tried. They're about to create a formal public-private dual practice system for doctors, and some experts say that it'll reduce wait times. Others say that it will actually hurt the public system.
Yeah, and today we're going to try to break down basically what this experiment really is, who wins, who quote unquote loses
Yeah.
in this situation, and kind of what this shift could mean in terms of like a national Canadian healthcare system. I mean, you kind of already know us. We introduced ourselves, so I don't think
Yeah.
we have to go through that again. But we could start with just kind of the first topic, which is what is like Alberta kind of proposing.
Mm.
So, Omar, if you want to introduce that.
Yeah, of course. So let's give a brief breakdown of what Alberta is actually doing here. So there's Bill 11, which introduces a dual practice model, and doctors can basically work in both private and public systems. It's kind of straightforward in that sense. And patients may privately pay for certain surgeries, so like hip surgeries, knee surgeries, all that stuff. And family doctors at the moment are kind of excluded from this now, and it is in the talks, it's in the works. So that kind of makes sense. And then emergencies, cancer care, all these other facets of healthcare kind of stay fully public for now. But the government argues that more choice would actually lead to shorter wait times, which is the main topic of this conversation. But of course, there are some kinks in that.
There's caveats.
Yeah, there's some caveats. And actually, for everyone's information, this model is used in Denmark, Netherlands, UK, Germany, Spain, and Australia. So it's not relatively new, it's just being implemented here for the first time.
So, I mean, that's a good thing. So
Yeah.
we know that it works. Right?
Yeah.
We know
Yeah.
that this is something that has been proven to work in other countries of the world.
Yeah.
But that being the big factor, which is other countries, right?
Yeah,
Canada's system is very different.
yeah.
We've had a public model for pretty much forever.
Mhm.
This public-private mix is doing well. It's done well. Arguably, what people assume is like the best healthcare systems of the world, which is
Yeah.
European countries,
Yeah.
or Scandinavian countries. And it's better than going full private, which is like US.
Yeah.
And where if you're broke, you're kind of gone.
We
But
both look at each other when we say broke.
okay, if you're broke as we are broke, then you're kind of gone. Hopefully you're not. But the question is, when you're kind of comparing it to, let's say, the UK, Denmark,
Yeah.
Netherlands, do you think Canada can like sustain this system compared to those? I mean, what's your opinion?
I mean, it's kind of tough because like on one hand, I really want to give Canada a chance. Like, see like what they're
I would prefer.
yeah,
yes.
yeah, like that would be great if they could. But the thing with implementing something new is that you kind of have to pilot test it first. With Denmark and all those other countries, I think it's pretty well spoken that they don't have much of a family doctor crisis as we do.
Yeah.
So we'll get into this in our conversation, but it really comes down to not just can we implement it, but is the system ready for it? If we have problems right now, do you think it would actually work with the problems, or will it exasperate it?
Yeah, and the other thing is, when you're saying we have a family doctor crisis, for sure.
Yeah.
Luckily for now, this isn't affecting that, but we also
Yeah.
have a physician crisis,
Yeah.
right? We are low on physicians, and
In
so
general.
I get the need of like you said, wanting to pilot test it.
Yeah.
But then it becomes a question of, is Alberta really the place to do that?
Mm.
Because surely they have less physicians in Alberta than they would in like Ontario and Toronto. So wouldn't it be smarter to try to do it in a more condensed location where there's more physicians? But then it's like, if you have more physicians in those locations, you usually
Yeah.
have more patients.
Mhm.
So it's like Alberta has less patients, so maybe there won't they'll be able to do the system better without having to worry about, affecting patient care.
Yeah.
But they also have less physicians. Or do they do it in like Ontario, where you have more physicians, but you also have what I think is like 90% of Canada's population lives in like Southern Ontario or something.
It's just a huge amount.
It's insane. So then you're having to deal with that as well. So, I mean, in the CBC article that like we kind of are, just to preface, we are basing our topic or our conversation on the CBC articles that were released like 2 days ago, 3 days before that, something like that. We'll add everything in the description of the video, and we always say this: we're not experts. We are people giving our opinion. This is a quick disclaimer. We're not like government policy people. We're not healthcare. We're not full-fledged physicians. Some of us in training. But so we don't have the most expertise when it comes to these topics, but we're just giving our opinion. Yeah. So, but the CBC reported say that emphasizing that big promise is shorter wait times. That depends entirely on whether doctors stay in the public side. So that's another issue, right? I don't know. Give me your thoughts on that.
Yeah, no, I mean, it makes sense. Like, if you're going to give another outlet for doctors to kind of move into a different system which will benefit their practice, who's to say that this model will ensure that the other side is still where it's at?
Exactly.
Like it's like opening a door for someone. Like, you're in a crowded bus, right? And then like there's another bus that's coming right behind it. There's a stop, and that door opens up, and you're congested in one bus. Why would anyone in their right mind stay on that bus if they have the opportunity to?
Sorry, I almost dropped my phone.
So this is one thing. When we do in-person recordings, you'll see these drops and stuff.
We're still learning.
Bear with us. Bear with us.
Sorry.
But yeah, coming back to that point, I mean, like, just the bus analogy, right? Like, if there's another bus that has more space, I would probably go to that bus if I have the chance. And we have, yeah.
Many times coming back from university, I have waited for a second bus that I know is coming like 3, 4, 5 minutes later.
Exactly.
Because I know 90% of the people on this bus is going to be packed. It's going to be so full, I won't be able to breathe. Might as well just get on the next one.
Yeah.
And so people are going to do that. More importantly, the private sector is gonna give more like money.
Yeah.
So it's a financial aspect.
It's more lucrative.
It's more lucrative. And that's where it becomes a decision of how do you actually get doctors to stay in the public system.
Yeah.
And there is something that the article is proposing that we will talk about. I don't know if we're talking about it in our next section, but we will mention it about what they plan to do and whether or not we think that's right or wrong, or whether or not we think it's going to work, which is, I think, the better question.
Absolutely.
But the other issue is when this bill was created, when it was put into legislature, it hasn't been formally introduced yet.
No.
So it's not in act. It's just in the process.
Yeah.
It's in that process. But the Alberta Medical Association was not consulted before the legislation was put on the table.
Alarm bells, alarm bells.
I can't whistle right now.
Yeah.
I tried.
You get the point.
Slightly better, but I don't know if you'll hear. But you're making a decision that's going to affect your entire province's medical staff and sector.
Yeah.
And you're not consulting their medical association. Like, there's
bound to be problems.
There's issues there already. So then this is where, in the second CBC article, which will be in the link, you had experts like Dr. Wurzbach, which said that most people trying this I don't know, call it situation, legislature, whatever, ran into problems. And then Dr. John Mendings, who said that he was not against private pay, but which came back to our previous point, which is that Alberta does not have enough physicians, especially anesthesiologists, which I think is huge because you need that for every surgery.
Yeah.
And you need them to stay in surgery. It's not like they put the person to sleep and then walk away.
Yeah.
Because you wake up on the table, who's gonna...
Yeah, exactly. Like, they have a role, continuous role.
It's a continuous role. This ain't medieval times where like you just knock the person out. You actually keep them.
Yeah, they're a genuinely key part of the system.
Yeah. And so it comes back to, again, that this is going to pull staff from the public system, right? So when you're comparing Alberta to Europe, it's misleading because they have more doctors. And it's one of the issues, that's one of the biggest issues about this situation. But I don't know, what's your take?
I mean, it's obviously the most concerning part is that the AMA, the Alberta Medical Association, was not consulted. And I think that's a huge thing that speaks to like how our system works when it comes to policy making.
Yeah.
Like the right people are not in the room when these decisions are being made. I feel like before you even go out with the megaphone and tell the world or that this is something we're developing, run it through the actual stakeholders who have a say and like an actual like, you know, benefit or outcome to this. So that is definitely concerning that
Yes.
the public knows now that they haven't been consulted. But I think the main driving point here is the quote that was written in the CBC piece itself, which says that part of the problem is that we don't have enough physicians to run two systems. Right? Like we have a weak input, so then it doesn't matter what fix you make. The weak input will obviously drown it with the noise. So what can we do there? Like that's a big problem.
I mean, if you're, then you do one of two things, or like, I don't know, maybe there's more options, but in my mind, the first two things that pop up, which is that either you accept more incoming physicians from immigrating like countries, and you maybe don't have them, you recognize their qualifications, because currently Canada doesn't recognize pretty much anybody's qualifications as someone who's already completed residency. You'll have to do your licensing boards and like a bunch of other stuff already. And being as Canada's largest immigrant population is from like South Asia, third world countries, right? They really don't recognize your qualifications. Some people have to, you know, redo their residency again, even depending on where you're from. So either you start recognizing people's work, you start recognizing their qualifications, or easier is maybe the wrong word, but other option is, for lack of a better word, breed more doctors in the country, which means more spots in med school, more med schools, etc., which is like slowly happening, but you can't change that overnight. I mean, what's the other med school that's opening up or something?
I believe it's York. Yeah, in 2028 or something.
Wasn't that supposed to be 2026?
I'm not sure. I'm not up with the timelines, but I'm pretty sure it's like 2028.
I swear at one point they said 2026.
Yeah, maybe it's been pushed. I don't know. You guys can check it out like on they're probably posting developments on it, but that's the next school that's coming up.
Latest one, TMU. Was just opened as a first inaugural class. Congrats. I mean, I'm surprised they got it open so fast. I thought it would take at least another year.
I think we all were like not on top of like how the accreditation was working, but it was a relief and a surprise to us at that time that it opened up right when application. Obviously, people know about like the delays in the application process, which is bound to happen. But these two schools are kind of like what's coming up right now. But like to add to your point, like that's just one small solution that has a long-term impact, nothing in the short term. And this bill, like, I don't know, did it say in the article when they plan to?
No, not that I recall. I remember in the article it was not mentioned of when
not
it
at all,
will be
right?
implemented. But I'm assuming they're trying to do it sooner rather than later. And let's say even if you open a med school today, the first class isn't going to be out for another 4 years.
Exactly. So again,
at the very least, you're waiting 4 years before you get a new set of additional doctors than more than you get every year. And aside from just doctors itself, that's like residency spots, right? Canada's so
that's
limited.
the bigger part.
That's the bigger part. Canada's so limited that a lot of people go to residency in the US. A lot of people try to find residency elsewhere, and then it's like you're doing your residency abroad. I don't know, would you consider it harder to come back after that or easier?
I don't know. Like I honestly, I'm not super well versed with like how you jump between US and Canada, but I do know that one of the main driving points to going to the US is that obviously it's more lucrative there. You can do multiple practices, and I think there's more room for opportunity for doctors there. And it's kind of funny because if that's something that's happening right now, what do you think is going to happen when you implement a dual practice system? You're kind of bringing in that same mentality, but just between practices within the same geographic location. So now you have a driving force right across the border, and now you have a driving force within our own country,
all taking you away from a public system. And for I don't know if anyone at the CBC is going to watch this, I highly doubt it, but whoever wrote this article, for mentioning the UK having the system, not going to deny that fact is true, but I know enough people who are like getting out of the UK's medical school system right now and are taking their US MLEs because they would rather work in the US because it's more lucrative.
Yeah.
Working as a physician in the UK in the NHS right now, you are making nothing, and
It's very tough.
I mean, it's a good system for the public. It's also has significantly long wait times, but lucratively, it's not great. And I know people in the system who've been working there for a while.
Yeah.
Who even they're like, well, if I didn't have so and so additional incomes, right? Then it would have been tough, because the golden age of like making money as a physician in the UK was like their dad's generation, which is like you're someone in their, I don't know, 60s right now.
Yeah.
So you know, it's a couple of decades ago that I would say is like the lucrative age of going into medicine in the UK. So that is an issue, and I mean, I'm going to go slightly off script in terms of if this kind of going back to whether or not this is how they're going to make this work. In one of the articles, the expert, the physician who's talking about it, actually said, like, you know, if you're going to make this happen, you need more doctors. And the one way you can do that is then stop putting caps on how many students med schools take per year, which theoretically is a great thing for anyone applying to be a med student. But med schools won't be able to facilitate that.
Yeah.
I mean, even if, let's say, they double their first year classes to, let's say, like every med school takes like, I don't know, 200-300 students a year, right? Majority of med schools right now, correct me if I'm wrong, by the way, is trying to focus slightly more on like small group discussions and having classrooms that are slightly more like group based than just direct lecture. I know, is that slightly what you?
That's what we have at our school, but like and Mac too. But like I think other schools also mix more traditional.
Okay.
Yeah.
Okay. So so we're seeing a mix there.
Yeah.
But for example, you do that with 300 students. Your like TMU and Mac aren't doing that anymore at that point, because you can't facilitate it.
It's hard
with the number of classes. And then let's say you take 300 students every year, and then when the third year comes, then you have to find 300 placements for clinical rotations.
Yeah.
And each have to be like, you know, 6 to 12 weeks depending on the rotation type. So it's extensive. So you can't, there's absolutely no immediate solution to what this change in system could cause. Unless, I mean, I don't know, I can't think of anything at least.
I mean, like, if we're talking about medical schools, I think it's less of trying to fix like people getting into medical school and more people going into residency, because residency is the closer to the goal, right, of like getting out. So I think if there is a solution in this area, it's probably going to be like with the residency spots. But on top of that, I think something that the article tried to address but didn't really talk about much is like the literacy of this law or this new rule to the current physicians who are practicing. And I think we'll get into that in a bit, but it's more so of like telling the physicians what you can do and can't do, because really like any impact on this bill comes directly or most importantly from the physicians who are practicing, not from the future physicians. Because if these physicians choose to stay in the public system, then we're all good, this thing's gonna work. But like if those physicians, a lot of them are like, oh, doors open, let's go, which we said in the beginning, then that directly influences how well this dual system works.
And so I think this is where we can get into it, which is like the safeguards that they're trying to put in the system.
Exactly.
If it is implemented, which, I mean, I'm not going to say it will be or won't be because we don't know, but it seems likely because of, if it is, it can cause a lot of issues. But the biggest positive is that it will be more lucrative, which, as we know, money is a huge factor in a lot of things happening in the world. So it's possible that that is enough of a driving factor to cause this bill to go through. But right now, there aren't many safeguards for this legislation. Government, like the bill that's being passed, has suggested trying to do something to adjust or allow that. Let me correct myself before I say something I not even understand. This is the issue with this. But it's to make sure that physicians stay in the public system. I'll start. Their premise is based off of what I think Quebec does, which is that med school students going into residency have to work, or like doctors have to work 5 years in the public system before they can try to do anything private.
Yeah.
So the idea is loosely based off that, which is, I think the safeguard, which I don't even know if I put in my notes, but I remember, is the idea that you have physicians only take private procedures or whatever on either after work hours or on the weekends. So what you're doing is basically saying this entire system that's public, you do your, which, I mean, I'm going to say 9 to 5, but we all know a physician's job is not 9 to 5. It can be significantly more, but let's just say it's 9 to 5.
Yeah.
So go to work, you're a physician, you have your nurse, technician, etc. Let's say you work in a hospital, you do multiple public surgeries, whatnot, 9 to 5. Your work day's finished. After that, you can start doing your privatized care work, which then you'll get paid a lot more for, or do it on the weekend. Now, I'm going to let you start, because I mean, I can assume what you think is already going to be an issue with that, with that proposed idea.
Already sounds.
Go.
Yeah. I mean, like, I can see where they're going with this, like to put a cap, because you wanna make sure that no one kind of quote unquote abuses the system and the outflow goes too much. But definitely, it's kind of scary to think about it, because there's no guarantee that these protections will actually remain firm. This doesn't sound like something that would be absolutely concrete, and I think there will be a lot of backlash actually. For people who are looking to benefit from a dual practice, they'll be like, why are you capping how much we do it, like after hours and weekends and stuff like that? So it comes back to, like, I can see the problems here, and I think you see it too, which is that they can easily be influenced to just go back on their words and just keep it like free reign. And we have to look into like the actual like rules of this policy. Like, obviously it's not open to the public, so we don't know much information.
And I think a lot of this can be changed while they're actually making it.
Exactly.
Even post like it being implemented, I think a lot of things might be easily be changed. Yeah.
I mean, it's just like, it comes back to good policy design, and like whether
this is good policy design,
and whether it like what's the other word for, like, I think like quality control of a policy or something like that. Like, who's gonna hold that rule accountable, and what are the decision-making tables and like these round tables, like what's the process of making sure that
all of that
we're keeping this in place, because it's not, then
I think. And then on top of that, there's like we kind of talked about it, burnout. Like,
burnout's crazy.
Like, you're doing a whole regular work day, and then you're like, because it's for the money, right? Like, it's enough of a factor to then get people to want to do the extra work after hours or on the weekends. And so that could be enough for then these physicians to be like, okay, well, my regular day, let's say I've done a 12-hour, 10-hour shift, 12-hour shift, but now I have these private procedures set up, and that'll make me like double the amount that I made for the rest of the day, or something like that, right? You're burnt out. It's not just the physicians, because obviously a doctor isn't on one patient 24/7, but you've got nurses, technicians, anesthesiologists. You've got a whole team of people that are potentially tired and burnt out. But they might still do it for the money. And then you've got patients on the other hand. They'll be like, okay, well, if I'm paying, why the hell do I have to wait till the end of the day? Right? Which comes back to your backlash of, if I'm paying, why the hell do I have to wait for the weekend? And more importantly, if I'm paying more, paying in general, why am I waiting for a physician who's tired? Right? I want them to like prioritize me. Right? So then it kind of maybe even leads us to like the next kind of idea is, then will this even reduce wait times because of that like priority and whatnot? I mean, we can get into that. I don't know if we want to talk about again about how this has no like limits of anything. If I remember properly, the article did say that like in the legislature there isn't like formally written down that the caps will be changed or anything like that.
It's nothing like is written properly. It's really just information that
it's
they
quite literally nothing is
Yeah.
concrete. So even for now, if they do this thing of like
Yeah.
only after hours, only on the weekends, that could change.
Yeah,
And
it
it
could,
could be
just be something that was brought up when making this policy, right?
Yeah, and then well, at that point, then
Yeah,
it all goes out the window.
yeah.
And then then it's like, would this whole thing work? Does it even reduce wait times at that point?
I mean, like based on what the government says, like they're like yes.
Basing it off the government.
Yeah,
right?
I mean, we have to mention it though because like I also recognize that like as much as we're talking about this topic and we're talking about the problems, we have to also like share the other side and see what they're saying too because it's kind of all these like we're just
for the people
for the people, but the government is saying that more pathways is less pressure on the system, but critics on the other hand, keyword being critics, are saying no because apparently it's already something like this was already used in the past, like chartered surgical facilities, and
okay.
they mentioned that, right? And then they said the wait times actually didn't improve at all, and we have mentioned this time and time again in this whole thing is that doctors could just shift to more lucrative private cases, and because of the shift, public system is still having that long wait time. So it's a negative feedback.
Because it's like, it's not you're implementing a whole new system with whole new people, right? That's basically the issue.
It's the same people.
It's the same people. So even if you do the after hours thing, then your prioritized paying patients are waiting till like nighttime or on a weekend, which I mean, who wants to realistically? Some people might be preferred because then they're like, well, I don't have to take a day off work and it's just on the weekend. But that's slightly separate. And then again, you have patients, and this is another thing that I just thought. It's like patients in the public system might feel that the doctor or physician, unconsciously or consciously, is just trying to get them through because they're like, well, I have paying patients that I would prioritize more. Yeah. So then
that's another good point, actually.
You're mentally affecting your patients who are trying to come to you for help, and you can talk about how that could potentially affect that. I don't know how much of you talked about that at school. I mean, it's a kind of a given. It's a whole course. I don't know, but like, I mean, obviously, like the patient themselves are taking their time out, and the patient themselves they're not only coming with their condition, they also can read the room really well, and they can know where their physician is prioritizing their focus. If it's really just on pumping out patients like every 15 minutes, it becomes obvious, and that's how reviews and things come up for those physicians. But you're absolutely right, because like again, it comes back to, if there's not a good safeguard, then realistically, if I'm a physician and I want to benefit from the lucrative practice, why not just end my clinic early? Exactly. And like, if it's all a matter of just, okay, you can do it after hours, but there's no like hard concrete thing, right? So then essentially the patients who are coming from the public system will kind of suffer from my choices. Yeah. And I mean, like, okay, I remember this slight anecdote story, but I remember once when I was having to go to that neurosurgeon for my back problem to see if I needed like surgery on my spine. She was obviously like, you don't have to do it, it's kind of a risky thing, this is mostly fix it by itself, yada yada. But the point was, for me, there wasn't a concern like, okay, I have to pay for this. For she didn't have to worry about, okay, is this patient paying for this? Yeah. Right? But if I go to that doctor and I'm going from public health standpoint, one, they're most likely giving me whatever appointment they're like free or whatever time slot they can fit. Yeah. As a privatized situation, maybe I have more freedom on that. So there is that perk of paying, which comes with a lot of things. But then let's say what did I have? I think I had to do it on like a Monday morning, and I had to go like, I don't know where, I had to go like Milton or something. Yeah. It was not close. And go there, have all this discussion, and she seemed very lax about the whole thing to begin with. Now, if I knew at that time that, okay, this is a system where she's probably just like, okay, man, just decide if you want it or not, right? Because it's not like I'll get paid the same amount, in the sense of like, if you don't do a procedure, government doesn't pay me, fine. I can schedule more privatized care surgeries and maybe make more money out there. Like, you're right, where patients can feel the interact. Sorry, we had some technical difficulties. Turns out our cameras might have a time limit of how long it records. I don't know.
Yeah, they
But
sadly passed away.
This angle,
but like,
this angle's so good. I think we're fine right now.
yeah, you guys can see us.
Yeah, you guys should be able to see us. So I was talking about how, like, basically we're going back to how patients can feel it and how that affects sort of the situation, which I think we have covered a lot, and the anecdote may or may not have been useful, but we should come into sort of what is our last topic, which is what happens next. Yeah. Right? I don't know. I'll let you start with this.
Yeah, I mean, what the article itself kind of says is that the AMA, AHS, and like all these like, you know, facilities and stuff will now be consulted on like how this bill actually looks and like what their opinions are. And the safeguards, as we mentioned, are there, but they may include like caps on private procedures, limits to like the evenings or the weekends, like Ali mentioned, and keeping family doctors excluded for now. So I guess the question that we could end off is, will this kind of be enough?
I still find it funny that they're now after bringing it up, after like releasing the idea, they're gonna consult the AMA, just like all these health organizations in Alberta. Like, let's suggest something, and then now that you've got a bunch of doctors saying that, okay, well, this may not work well, now we'll get your opinion on what you think it's gonna do.
So, and it's kind of like interesting because like you would think policy is like the other way around, right? You'd first consult, like get all the stakeholder
discussions,
so
have something.
I think, not to be super controversial, there could be like a public imaging agenda behind it of like, oh, let's tell everyone that like, here's like, you know, we found a solution, but we're gonna work on it now.
Because I mean, I think that's actually so true, because let's say you put this out, right? Now you've got maybe, I don't know how many doctors there are in Alberta, but let's say thousands, maybe a stretch. But let's say thousands of doctors and people thinking, okay, well, now I can get paid more, right? If I pay, then I can get more priority, less wait times, you know, stuff like that. So you've got maybe somewhere in people's minds thinking, okay, this should happen, this could happen.
You get people talking.
Exactly. You get people talking, it becomes a discussion, and then it's like, now you've got the ball rolling. So it's hard to stop. You already had 2 articles on it. Like, CBC is not a small...
nationwide, we use it,
nationwide, right? So will it be enough in terms of the safeguards? I think probably not, but at this point, like, there's potentially no stopping this bill from actually being passed. I think trying to the storm it can and maybe has created in the medical community to then go from like, oh, suggested this whole thing, to then absolute disappearance and silence. People, a lot of people will be like, well, you know, what happened to that thing you suggested that would have us either be paid more or have us get more priority if we pay, type thing. So in terms of future, will it be enough? Then that we'll have to see. We've seen what's happened with the UK. Their public system is like, you know, suffering significantly. And they have a good amount of doctors, but their population is also significant. So I think it matters more about population to doctor ratio rather than just one or the other.
And just to add, like, I would be interested to know that when they were making this, did they consult those other countries that they got inspiration from?
Unlikely. I doubt they consulted. I think at most they looked at their systems, seeing if like on a large scale, like global perception, do people think it works? Because I mean, like, it's important though, right? Like to get there, because they're the ones who have experience in these things. So like they could probably warn us to like, you know, stop. Like, do better,
or don't do it,
or don't do it. Like, it's either do better. Depends who you're asking. I think.
I guess
UK will probably be like, either don't do it or it's make the switch. If you ask the US, they'll just be like, switch it entirely to private, and then everybody gets money. And if you don't have money, you're dead.
It's concerning.
It's concerning. Like, there's a whole other system. There's the opposite of that issue. And then places like Denmark, I think Netherlands, they have good healthcare systems, and it works well. They might be like, okay, well, yeah, it works, but we've set this up for, you know, how many years. If you're going to do a quick switch in a small province and you don't have
current concerns already, shortages,
then you have to be the one to decide. And again, if you're putting it on the government, it's maybe and then leaving it up to physicians who may see it as an opportunity
Yeah.
to get private like funding or
Yeah.
the private I don't know, what's the word, pay.
Yeah.
They might be for also.
Yeah.
I don't know if we kind of already answered this, which is like, is Alberta setting up a future political fight between public defenders and private supporters?
It's being instigated like slowly, but like I'd say like it would be harsh to say a fight right now. It's more so just like conversation and possible disagreements.
Yeah, like no one's gonna go out in the streets and start
Yeah,
fighting
yeah,
each
yeah,
other.
like private public, like it's not like that. But definitely it will get people thinking. I think it comes back to that point that when you share the news before anything's set in stone, you get people talking, and you kind of instill in people's minds what side they want to take.
Exactly.
Yeah.
And then it's like you can't get it out. You can't just like disappear from it.
Yeah. But I think at this point we might as well wrap up because we are hitting
our usual like 30-35 minutes.
40-ish minutes. Apologies for the camera switch once more.
This is the first time trying it.
Yeah,
we'll
have
figure
some
this
mercy.
stuff out a bit better next
But
time, hopefully.
we hope you enjoyed the quality of the recording this time and maybe the setup and us being
Hopefully,
not on Zoom.
Yes, that's the other.
But yeah, just to give a quick takeaway on what we've talked about, dual practice isn't inherently bad. But Alberta doesn't have the staffing levels that other countries do, and nationwide we have a shortage.
Mm-hmm.
So without strong legislative safeguards, this could cannibalize the public system possibly.
Yeah, wait times are a real crisis. That's not a secret to anybody who lives in Canada and has at some point they've been in the healthcare system, even for like primary physician appointments. But shortcuts rarely solve the issue, and this is more or less a shortcut because it's not being well thought out. It's not being built from the ground up. It's just been introduced.
Yeah.
So that is a concern. And then if Alberta really wants change, they need more doctors, and whether or not you do that with building more med schools, which again is not a quick fix or quick solution. It's a 4-year-long commitment.
Yeah.
Or you start letting more people practice, more immigrants practice, which I mean the concerns of that are always just about, can you trust someone else's or some other country's training? So those are all issues that need to be weighed before something like this goes into practice, and which is kind of what we're not seeing right now. At least it wasn't thought of much before it was introduced. Whether or not it happens before they actually pass the bill, whole separate issue. But I think now we should come to a close. Thank you everyone for watching. Thank you for listening to this hopefully dynamic
we tried
podcast. We'll figure out some other stuff in the future. What's the other stuff we say? Like, subscribe.
Follow us on our Instagram at Advocate Health. We will be trying to get more guest speakers. Maybe have some coming in the next month or so.
Unlikely for that to be in person because my room isn't that big.
No. Like this is not our official studio yet, but like it's something that we want to continue doing at least once a month. So you expect to see us do this at least once a month, and then if reception's good from you guys, you really like it, we can continue.
We'll figure stuff out or how to make it more like this. But thank you all, and see you next time.
See ya.